Welcome to the Dr. Geo Prostate Podcast. Today, Dr. Geo sits down with Dr. Jacob Meyers, Director of Research and Development at Lynx DX. With a fascinating background in biomedical research, Dr. Meyers brings a unique perspective to prostate health. Together, they explore MyProstateScore 2.0, a new urine-based test designed to give men and their doctors better information when deciding on next steps, including whether a prostate biopsy is truly needed. Get ready for an eye-opening, informative discussion. Let's get into it.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo. And you know what we do here? We want to optimize your prostate health. We want to optimize your overall health, and maybe you don't even have a prostate. And we want to get it right. And today we have Dr. Jacob Meyers, which you know about from the intro. And you're probably wondering why you're wearing a cap that's a Knicks hat. Well, I met Jacob at the AUA in May. And at that time, he is out in Michigan. And of course, the New York Knicks, and if you are into basketball, they were playing a very tough series against the Detroit Pistons. And we were kidding back and forth, and it didn't look good for the Knicks, but eventually they came up and they won that playoff series, and they still now, at the time of this recording. And as you know, I am a New Yorker, and I am a Knicks fan, so I kind of wanted to play around with Jacob a little bit and just wear. I hope you don't mind.
No,
Jacob.
At least you didn't make me wear a Knicks hat for this one.
That's right. That would have been good. We would have had a bet, that if the Knicks win, you wear a Knicks hat, and if the Knicks, the Pistons would have won, I would have worn a Pistons hat or shirt.
Maybe next year.
Which I don't think I would have minded. I love the Pistons, particularly those from the bad boys from back in the day.
Yeah.
So, I would not have mind. Thanks for being on, Jim.
Thank you for having me.
So you're the head of R&D at Lynx DX, the company that produces the MyProstate 2.0 urine biomarker. So we're going to dig deep into that. I already have Dr. Tsoyan, who in an earlier podcast, he spoke about it from a clinical perspective. I know he was one of the ones, he was like maybe a fellow or something. I remember him saying when he was at Michigan working on this biomarker. And here we have you, one of the scientists involved behind. So it's great to have you and see your perspective. So you have a PhD in applied biomedical sciences with field work in malaria research in Ethiopia. Then you developed IVF genetic testing at a lab. And my question is, what does any of that have to do with prostate cancer and biomarkers in prostate cancer?
Yeah, probably a less traditional path to get into this kind of prostate cancer diagnostic research. So my early work was doing my PhD and postdoc was related to malaria transmission, really studying mosquitoes. But really there are so many parallels when it comes to figuring out ways to get genomic signals out of these organisms and find meaning and insight from these genetic signals into phenotypes or behaviors or physiologies. So I started my work with mosquitoes and malaria, really going from all the way from the molecular end, cloning genes and studying the genetics of mosquitoes, all the way through doing field work. Most of it was in Burkina Faso. But then when I came out of my academic life, ended up joining a company. As you said, we developed a test for the IVF lab to do genetic testing for embryos. And there were so many parallels because, again, in this space, you don't have a lot of material to kind of capture these genetic markers for diseases and abnormalities. So we're working with these, 150 cell embryos, and you can either take a biopsy of just 5 of the cells, or we developed a method to take the media or the liquid that they're grown in, so we could non-invasively assess their genetic status. And the tricks and tools I learned in these other systems, I was able to apply when I came here to Lynx DX and trying to figure out ways to take a man's urine and determine the health of his prostate. specifically prostate cancers. So while they sound very different at first, I think there were a lot of parallels that really helped me succeed here in the prostate cancer world.
And to be clear, these are not mosquitoes that have prostate. I don't even know if
No,
mosquitoes have prostates,
they
by the
don't.
way. They
No,
don't.
not at all.
Okay.
No,
Okay.
no, no.
That's a very interesting thing. I'm not going to ask any more questions about that, because then I'm just going to go into a deep dive on mosquitoes and their biology and so forth. And I don't have the time. I don't have the
Maybe
time
another
for that.
time.
Yeah, but maybe maybe you would you consider yourself expert in mosquitoes biology a little bit?
I used to for sure be. It's a little bit rusty, but I know more than your average Joe. I'd say that for sure.
Yeah. Well, that's at our next meeting or dinner or coffee. Maybe we can talk
Absolutely.
about
Love
that.
to.
MyProstate 2.0. So a few papers came out, JAMA, Journal of Urology, which I think that's the one that caught my attention. And that's when I said, oh, shoot, this is a big deal in terms of a biomarker that's better than PSA. To be clear, PSA is a good biomarker. I think most men walk around with normal PSA, 90%. So it's that it's inexpensive. And one can just do a blood draw and kind of see what it is. There's been a lot of problems with PSA in the past, of course, with regards to over treatment and over biopsying. And that's the issue. So it's not great for screening. So for the audience, don't throw out the baby out with the bathwater. PSA is a very good biomarker, but there's other things other biomarkers that are more sensitive to prostate cancer. So MyProstateScore 2.0 is one of them. Why don't you expand a little bit of what this biomarker, what MPS 2.0 is actually looking at to determine, and I have to say one other thing, and you just course correct me if I'm wrong, how MPS 2.0, along with the other more sophisticated biomarkers for K-score, Phi, ExoDX, they're trying to determine not if the person has prostate cancer, but if they have a little bit more of the aggressive type that we should pay attention to. So it's trying to ignore or overlook the low risk disease that we don't care to. So expand on the development of it, and what is it?
Yeah, absolutely. The development and discovery of the biomarkers. It began with really assessing about 60,000 potential biomarkers that might explain or might predict a healthy prostate from a prostate with cancer. And there was a large next generation sequencing based study to evaluate these nearly 60,000 targets between these tissue types. And it was narrowed down to 54 targets, which were then deeply evaluated in the urine from men with and without prostate cancer, and then eventually distilled down to just 18 biomarkers that make up MPS2. And the way they distinguished...
Why was it distilled down to 18 and not keep to 20? Was there a better signal with these 18 than the others? Eventually with the others, as best as you can guess, the others will be included if there's more research done. Why 18 and not 24?
No, that's a great question. So from the 54 that were evaluated in the urine, we used different machine learning approaches to determine which were the most important genes, which ones had the most distinct signals and not parallel signals between, gene A and gene B could give you the same signal, just be in parallel, and which ones work best in concert to give us the highest performance in predicting prostate cancer. And it really distilled down through this kind of machine learning process to these 18 targets.
When you say machine learning, is there an AI element to it? Is that what you're implying?
Yeah, machine learning is kind of a subset of AI, I would say. It's not like ChatGPT where it's coming up with complete answers for you, but it's different types of simulation-based machine learning approaches to really distill and pull insight out of quite complex data. Yeah.
So then you came up with these 18 chemicals that suggest we need to pay attention.
Exactly. And I should say, too, we didn't just distinguish between men with and without cancer. I should say men with that indolent or low-grade cancer were grouped with the healthy men. So we actually did distinguish between high-grade, grade group 2 plus cancer versus grade group 1 or no cancer. So that gets towards your earlier point of really trying to our test enhances PSA in terms of being able to distinguish those higher grade, more aggressive cancers.
And to be transparent, I have not used MPS 2.0 yet because you guys are doing great work and trying to get it approved in New York. And so we're looking forward to that.
Yes.
So I don't have firsthand experience with it, but I read the research, and again, compelling. Some of the research seems to compare it to other biomarkers like 4K and prostate health index, or PHI. Expand on that?
Yeah, so in our first validation, and this was conducted by the National Cancer Institute through the NIH, it was directly compared to PSA, to clinical factors alone, as well as PHI. And at MPS2 greatly outperformed PHI. So at the same level of sensitivity and NPV, which are the characteristics most important for distinguishing men without prostate cancer, MPS2 had nearly 3 times higher specificity. And what specificity allows you to do is detect more men without cancer. So it has very strong utility in really being able to identify those men with high PSA that don't need to go on to a biopsy and help them avoid what some would call an unnecessary biopsy.
Which is the ultimate goal,
Absolutely.
right? The common saying that I have here that the audience have heard over and over again is, I have yet to meet a man that wakes up in the morning and says, my goodness, I can't wait to get a prostate biopsy today. I mean, this is right. It's invasive. And this is kind of my discussion with many of my colleagues, urologists. I said, because I'll just get a biopsy. I said, no. I mean, put yourself, first of all, let's get a group of urologists in a room, raise their hands. How many of you have gotten a biopsy? Very few hands go up. And there's no way their PSA is not high and so forth, right? So no one really wants it. In 2025 and likely in 2026, it is the only way to really diagnose somebody with prostate cancer, is the gold standard. Maybe that'll change in years to come, but this is what we have. So there's the value of this type of urine test, where many of my patients look for my services to help them navigate, and says, hey, my patients have trust issues with their doctors, is what really happens. And they're saying, well, he's a urologist. Of course he wants to do a biopsy. So they come to me to help them navigate and say, do I really need one? And so then the first conversation is the only way. So let's put some of these data points together and make that determination between the two of us and know what your risks are. So this is why MPS2 is exciting to me as a clinician.
Wonderful.
The 18 RNA biomarkers, I don't want to get too much into the weeds because they have a bunch of letters and things like that may be irrelevant. But tell us a little bit more about these 18 biomarkers. Roughly, what are they, and how is it different than other urine tests and biomarkers that says, look, these 18, they're the one. For example, one of them is PCA3, if I remember correctly. When PCA3 was the only biomarker utilized back in the day, it might be the first urine test, which was exciting back then. It caught a lot of cancers that were low risk. So my question is, why include PCA3 where it's been proven to not be so great clinically? Why include PCA3? Or is there some benefit in the synergy of the 18? Hello, friends. I just want to give a warm welcome to our next sponsor, Lynx DX. As you know, 1 in 8 men will develop prostate cancer during their lifetime, and screening does matter. But common approaches like PSA testing alone can be misleading and oftentimes is elevated for reasons that are unrelated to cancer. That's why Lynx DX developed MyProstateScore 2.0, which is a simple, non-invasive urine test that helps you understand your true risk of having clinically significant prostate cancer. We're talking about Gleason 7s or higher. MPS2 uses 18 unique biomarkers to give you a personalized prostate cancer risk score. The test is accurate, whether your urine is collected in the doctor's office or at home, and is designed to help you and your doctor understand what is the next step, whether there is more testing involved, imaging, or a biopsy. Talk to your doctor today to see if MPS2 is right for you. Visit lynxdx.com, that's lynxdx.com, or look below in the show notes for the Lynx DX link.
Yeah.
I'm curious.
That's a great question. So PCA3 alone is a nice biomarker, but you're right, it does pick up a lot of indolent cancer. And within our algorithm, it's properly weighted along with the other 17 biomarkers so that its weight is more reflective of when you have more clinically significant grade group 2 plus cancer. So probably our most special biomarker is the TMPRSS2 ERG fusion, or we call it the T2 ERG fusion.
Talk a little bit about that, because I think that is one of the impressive elements of MPS2.
Absolutely. So we're the only test that detects this fusion, and it is an actual fusion within the genome between two different sites on your 21st chromosome. It's this gene called TMPRSS2 or T2, and it fuses with this ERG gene. And when you have this fusion, it can drive prostate cancer, or it does drive prostate cancer. So of our biomarkers, I'll say that one's the most heavily weighted. We are the only ones that measure it. And it's very important to an individual's risk for prostate cancer. And then the MPS2 score that we generate. 4 of our biomarkers are specifically tuned for only high-grade cancer. They're just a bunch of letters, but they were discovered and they specifically are built into the algorithm to predict clinically significant prostate cancer, while the remaining biomarkers like PCA3 kind of more help the score in discerning if you have cancer or not. So there are different genes that have kind of different roles, and they're all weighted differently within this machine learning algorithm to best predict an individual's risk.
There is a biomarker that is, I want to say PSA within one of the tests, right? And so differentiate, is it Kallikrein 2
3,
or something
yeah,
like that?
Very good.
Kallik 3. And so differentiate between the Kallikrein 3 or the PSA biomarker that I would get from a blood test versus a urine. And if we're saying, if there is no difference, you're going to let us know. Why include that when PSA is an issue? There's even more false positives with PSA. So maybe you can.
No, that's a great question. So first I'll talk about PSA. So PSA, or prostate specific antigen, it's naturally produced by the prostate, and it's naturally produced at high levels. But when an individual gets prostate cancer and has a lesion, this PSA starts leaking into the bloodstream, and that's what you're detecting with a traditional PSA test. Also, once you have cancer, the prostate itself actually starts producing less PSA. So while you see more in the bloodstream, the cancer is causing the prostate to produce less. That's also producing leaking. So it's kind of a noisy, kind of indirect way to look for cancer in an individual. KLK3 is the RNA signal upstream of PSA that is being produced by the prostate, and it's getting released into the prostatic fluid, which is secreted or expressed into the urine. So we can detect it much more directly. And actually high levels of that Kallikrein-3, or we call it KLK3, is indicative of a healthy prostate. And as that value goes down, it's more indicative of a potentially unhealthy prostate.
So you're not, just for clarity, on the blood tests, there's less PSA produced, but more PSA leaked in a situation like prostate cancer. In the urine tests, there's a higher PSA, more PSA produced, but less leaked, or the other way around? Not leaked, I'm using the wrong terminology, expressed in the urine.
So it's always consistently expressed into the urine. So we can more directly measure how much of this PSA signal through KLK3 is being generated by the prostate through the urine, because it doesn't require a lesion for it to leak into the blood, because it's naturally kind of being expressed or flows into the urine. So it's kind of a better signal.
So more is better. Whatever more is better from a urine perspective.
Where more in your blood is worse. Yes.
Okay. Are there any nuances in any other of the 18 biomarkers that you think is worth talking about? Like this is actually, from a clinical perspective and a curiosity perspective, I think TMPRSS ERG ratios are important. Kallikrein 3. Is there anything else that you say, yep, let's talk about this one other one? Any others that come to mind?
No others really come to mind. I'd say the 3 we talked about probably are the most unique ones and kind of relate to kind of other tests, whether it's PSA or other biomarker tests, and kind of historical biomarkers, I'd say, for prostate cancer. Yeah.
When I have the opportunity of ordering a MPS 2.0 and I'm jotting down all the relevant information, will I have to input other clinical data like blood PSA, ethnicity, family history? Because to me, that kind of muddles. How do I know that this is not, influencing the result?
Yeah, that's a great question. So we've talked with panels of urologists about this, and we see a diversity of opinions. Some want these clinical factors to be a part of the test, and many are like you and do not want it to be part of the test. And so we've worked hard to really accommodate all these different opinions and all these different ways that physicians want to practice. So you can order the test as a biomarker only, or you can put on the test requisition form, I would like clinical factors included in the test, and then you would fill out this information. So we have different algorithms if we're going to use the biomarkers alone, or if we're going to use the biomarkers with kind of your classic clinical factors. And then we have a more advanced one that includes the clinical factors as well as prostate volume, which we don't always have, let's say. So we have kind of three versions of the test that can be ordered. We've also done a little more customization and more algorithm development for men that are considering their first biopsy, initial biopsy, as well as men who have a previous negative biopsy, which we've been able to algorithmically determine, kind of comes up with a different profile of biomarkers that we can use to better predict prostate cancer for men that we know previously maybe show high risk for prostate cancer, but they've previously shown not to have prostate cancer. So we have quite a few algorithms kind of under the hood. We try to make it simple and flexible and give the physician and patient a lot of options in terms of how do they want their score generated? Do they want that pure biomarker only score, like you said, or do they want as much information as they have to be put into the algorithm, which might personalize their score a little bit more?
So it's optional to the clinician.
Exactly.
Very nice. What results, when the patient or the clinician gets the result, is it like a 0 to 100? What's the cutoff? Is there a cutoff point? So if it's above a certain point, yep, you're in trouble, or yep, you need a biopsy, or below? What are we looking at?
Yeah, so it's a combination of both. So you get a score from 0 to 100%, and this is your individual risk for prostate cancer, your individual positive predictive value, the scientific term. And then we also compare it to a threshold. So for us, we use the 11.5% threshold. If you're below that threshold, you have a very high NPV, where we know with a lot of confidence that you will not have cancer. And this is depending on which model you use, this can be 93% up to 99% sure that you do not have cancer. And then if your value is above the threshold, you're really directed towards your value. So if you have a score above 11.5, let's say you're 15%, that means you have a 15% chance of having clinically significant cancer, versus 70% truly means you have a 70% chance of having cancer. And then through really shared decision making between physician and patient, you can determine what's right for you in terms of how much risk you want to take, and or if you just want to go forward with biopsy.
So if a patient, 11.5 seems to be the cutoff where we feel very confident that there's no important or prostate cancer that what if it's 13?
What if it's 13? So you would be above our cutoff, but that would be your individual risk. So you would be at 13%. And we've gotten feedback from many physicians that, if they get a score of 13%, they actually don't go forward with biopsy, and they
probably depends on just how I've used other urine tests, Select DX, which I have, and Exo DX, putting the whole puzzle together, MRI, PSA velocity, and all family history, things
absolutely.
Like that.
Yeah. We even hear from some physicians looking at kind of MPS2 velocity over time and seeing how that percentage changes over time and having that influence the decision making. The value itself has true meaning in terms of the percent risk for cancer, which has its own utility.
One of the clinical benefits, look, I don't really, as a clinician, I don't really care to do prostate exams unless I absolutely have to, or do prostate massage unless I absolutely have to. And I definitely don't want to massage their prostate so that we get more material from their urine. Some of the urine biomarkers requires it, others don't. Where is MPS2 in this situation?
Yeah, great question. So historically, MPS2 did require that prosthetic massage prior to urine collection. But more recently, over the last couple of years, we've been working very hard in R&D to take away that requirement. And we've really optimized our RNA extraction and amplification process so that it's no longer necessary. And that was the publication you saw at Journal of Urology earlier this year that clinically validated our method. So we no longer need that digital rectal exam or prosthetic massage prior to urine collection. And this test is offered now at home. So we can ship kits directly to patients' homes. They can do a very simple urine collection there. We send it with a box that they can ship back to us. It's very simple, no ice needed. It comes right to our CLIA CAP lab here in Ann Arbor. We run our test and send those results back to the physician. So we've really simplified the process and made it much more clinically friendly, patient friendly for people to use.
Look, easy always wins. It always wins. It's fascinating to me where when a representative of a company says, look at the data of our product. And clinically, it's all about easy.
Yeah.
We want to make it easy for the patient. We want to make it easy for our office and our practice.
Absolutely.
So that's a very important component that it makes MPS2 even more appealing, I have to say. So we have a situation, patient high PSA gets a MPS2, they're trying to avoid a biopsy, and it could give you some indication of whether or not they need a biopsy. One of the methods of how I use ExoDX which is another urine test, and a lot of the audience knows about it, is for men on active surveillance. So men on active surveillance are trying to avoid subsequent biopsies, of course. And it's, I've used it, and now then lately I've used it before they published on it, off label, and now they have published literature. Can MPS 2.0 be used in men on active surveillance to give us some indication if they need a subsequent biopsy or not?
Yeah, great question. So yes, that's a very, very difficult test to do, to really be able to distinguish those men with that indolent grade group 1 cancer versus something more aggressive, grade group 2+. So we are currently working on that validation. It's going very, very well. We've been very happy with the data present that we're observing. So we're doing this. It's a multi-center study with 10 sites across the United States. We're well on our way through this validation, hoping to have it published and available first half of next year, I hope. So while the data isn't quite ready and published yet, we are full steam ahead, and the data looks great. And I'm very confident that I think it can work for that indication and be another great tool for men to really monitor their prostate cancer and determine if they do really need to go in for another follow-up surveillance biopsy. Yeah, absolutely.
Jacob, looking ahead, right? What's your best guess? Do you think that you will narrow down the biomarkers that are utilized to the top 5, or do you think that eventually you probably can potentially add other biomarkers that can make this test more robust? What's your thinking?
Yeah, that's a great question. So we've been finding new.
I know you're speculating. Yeah. Scientists hate to speculate. I'm aware. The data doesn't show it. We don't say it. I got you. And we're not going to hold you to it. Just, top. I'm just curious to see where this is going to go moving forward.
Yeah, I think, so we have some very preliminary data on ways to improve our biomarker discovery process and really improve our ability to predict prostate cancer. So for MPS2 and other tests like the ExoDX and SelectMDx tests, you hear about it as a rule-out test. It's designed to rule out the need for a biopsy. And these tests have a lot of confidence. If we tell you you're low risk, all these tests have over 90% NPV, 90% confidence that you don't have cancer. But if you're above their threshold, above their cutoff, then it's a little bit more of a graded risk, which clinically it's a little hard, right? You'd rather have a yes, no, thumbs up, thumbs down. So, I think we found some molecular insights on what has limited the biomarker tests to this point to these rule-out tests, right? And I think we've kind of discovered why we're hitting that ceiling. And yeah, it's a combination of discovering new biomarkers, utilizing them in a different way, potentially subtyping people, that I think we can really break through that ceiling. I think we're a few years away from that, but we have some very exciting early data that holds a lot of promise to really take these tests, not from just a rule-out test, but more so closer to a true diagnostic test, a true yes or no. So I'm very excited for the future.
Yeah, so am I. What else is down the pipeline for MPS 2.0? What will MPS 3.0 look like? I guess that's a repetition of the question, but can it eventually, you think, can tell us more specifically, more the aggressivity? Because there is such thing as low intermediate risk prostate cancer. I'm not even sure if I want to always find those, honestly. So it depends, right? I don't want to find those necessarily many times. I think there's a lot of data around that. So do you think that it will focus more on the high intermediate risk and above at some point? Is that even possible?
Yeah,
moving forward?
Absolutely. As we look at our active surveillance data, that is Absolutely, one of the endpoints or the outcomes that we're looking at is not just predicting grade group 2 plus, but really being able to distinguish between those favorable intermediates you just mentioned that you might want to keep on active surveillance versus the unfavorable. There are lots of prognostic indications that we're considering looking into and looking at recurrence after intervention to see if MPS2, MyProstateScore 2.0, has utility there. So there's a lot of space, once a man's been diagnosed with prostate cancer, where this biomarker test could potentially have utility. And we'd like to see how much it has and how far it can go as well. So we're always looking at those opportunities as well.
I love it. Dr. Jacob Meyers from Lynx DX, the developers of MPS 2.0. Jacob, any final words? And how can people learn more about this test?
Yeah, to learn more about the tests, if you can go to our website, we're www.lynxdx.com.
That's lynxdx.com. And of course, it'll be on the show notes. And it's our sponsor for this month, the month of June. So our audience will hear plenty.
Wonderful. Yeah, so it's very easy to find our contact information. Feel free to email or call our customer success team to get more information. And yeah, Dr. Geo, thank you so much for having me. I've really enjoyed this conversation. Hope to talk to you again sometime soon.
Completely my pleasure. And I can't wait to talk about mosquitoes at some other point. Probably not on the
Probably
podcast.
not.
I have to ask you, so the Knicks are down 3-1. They play tonight. You think we have a shot?
I do. The Pistons were up
against the Indiana Pacers.
Pistons were up on you guys. I think almost every game that we played, and you guys came from behind and, won 4 of them, So, yeah, you gave heartbreak to one Midwest team. I wouldn't be shocked if you did it again.
It's tough. They look a little banged up, but we'll see. We'll see. Hey, thanks again for being on. I know you're a busy guy, and I appreciate you being on and sharing about this novel biomarker that I think is going to be a good one for clinicians and patients.
Thank you so much. Really enjoyed the conversation.
Thank you, everyone, for watching, for listening this podcast on a novel biomarker for prostate cancer. This is part of the conversation. Maybe your physician doesn't know about this test. Maybe you can ask them about it and ask them if they can order it. Sometimes, what you are, in my mind, you're a self-health advocate, and you should advocate for your health and be well informed. That's what we're about here. So empowering you. Thanks again for listening. Thanks again for watching. I hope you enjoy it. Please don't forget to subscribe, like, comment. I read all of them. I can't reply to all of them, but I do read all of them. And stay well, stay strong. And if you do have prostate cancer, remember, you're a thriver, not just a survivor. This is Dr. Geo signing off. Much love to you all. I'll talk to you next time.
We hope you enjoyed this episode. You will continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more.
If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.